Start. So thank you very much for joining. This is the second installation of a journal club that we've coined Phronesis, which is a type of particular wisdom we hope to share and grow. And the idea here is to have a journal club where we talk about a clinical case and a related paper, and also then feedback just with the group's experience and thoughts about both and how those interrelate. And the idea is it's supposed to be bigger than any one unit. So we initially had an idea of growing along the M40 corridor from Chelsea down in London, out past Wrexham, Stoke, Mandeville, Oxford, and up towards Coventry. But lots of people seem very interested, so we're really keen to grow this further. And it's really nice to see on the participant list there that lots of people have joined us from all over. So we're all very welcome. Thank you very much for joining us this evening. The case this evening is presented by the team from Chelsea, Westminster. So we've got Max Horwitz, the consultant hand surgeon, and we've got Rob MacFarlane, hand fellow. And we're pleased to welcome Ian McNabb and also Carlos Haras-Palou as our invited panelists to comment on their thoughts in particular about paediatric scaphoid non-union treatment. Everybody else is an attendee, which means that you can add questions on the Q&A. Please add your questions in Q&A rather than on chat, and then we'll tackle those and read them out after the presentations. So most people have completed the poll. James put this on the screen. So the vast majority of people have not come across paediatric scaphoid non-union. So hopefully there'll be a lot of learning for all of us. There are some real experts out there who've treated more than 10, but most people have treated fewer. So without further ado, I'll hand over to Max.
Hi, good evening. Well, thank you so much for inviting me, guys, and I'm glad we set this up. I think very few people see lots and lots of scaphoid non-unions in kids. It's rare, and don't feel bad if you don't. I've chosen a case that we can go through. Kids and teenagers and adolescents fall over a lot. They play all kinds of sports. Wrist hyperextends and it fractures like anyone else in terms of a scaphoid fracture. Scaphoids make up 3% of kids' wrist fractures, but really, of that 3%, only 1.5% go on to a non-union. So it's a bit of an esoteric journal club, but I think if you just get one of these right in your career, you're going to be a very happy person. So I hope this is useful. I found it interesting. This is the case. So I'm in London, I'm treating various footballers from various clubs, and this, I'm just struggling to advance for some reason. The 17-year-old comes to my clinic and he comes in with his manager, he comes in with the physiotherapist, and he comes in with his mum. And the story goes that he was in the goal and hyperextended his wrist. And as you know, people jump really high these days. They hit the ball unbelievably hard. He had a sprained wrist. For those of you who've done this before, you've heard the story 100 times. The sprain of his wrist got better after a couple of weeks and everything was ignored. So I see him 10 months later and we get an x-ray and there's a bit of a cystic area at the proximal pole of the scaphoid and it's becoming more and more sore. So he's 17. He plays for the other under 17s, the under 23s. He's played for England at the under 18 level. His mother's in tears, his coach is worried, and his physiotherapist is looking guilty. And I say, well, look, let's not make any decisions. You never know what's going on. Let's get some further imaging. So obviously, private medicine moves along quite quickly, and we get this images in the clinic. And instead of reassuring, I mean, if all of you can just maybe move this corner on the column on the right-hand side, you'll see the whole slide. You can see that it's not looking that nice. We've got a proximal pole, which is filled with holes and cysts. And, you know, it's really almost going into the radiocarpal joint. You can't quite see the cartilage on a CT scan, obviously, but not looking great. And where I work, the radiologists are really friendly. And just in case you miss it, they put these nice big arrows over there, just to make sure that you can see the non-union. So at this stage, I'm sitting there with the family and they go, what are you going to do, doc? we started the season. There's great hopes for him to play in the Junior Euros. Can you fix it? It's always assumed he's 17, you're going to fix it. So there's two parts to this. The first thing is making sure you treat the family, treat the patient. If you're used to treating sports people, I think it's really, really important to treat them like every other patient. Don't be influenced incorrectly. I think at the moment, there's all kinds of stuff going on in the UK with regards to sports and COVID, and you can see sports people aren't being treated the rest of the same as the country. So you've always got to, in these situations, I feel, you're treating a patient, he comes first, she comes first, take their opinion into account, take the family's opinion into account. Make sure that you're taking care of them like you would any other patient. So I took the time and I explained what a non-union is. We went through the anatomy. Then I explained that there's good scaphoid breaks and bad scaphoid breaks. And I went on to show them that unfortunately it's in the bad place and then there's a cyst. I sold it as quite a bad thing that I might not be able to heal. I spoke to clever people, some of whom I'm very lucky and privileged to say are on the panel this evening, who gave me advice. And I documented it in my clinic letters. And Mike Hinton always talks about this when he gives a lecture. Document in your records that you have spoken to other experts. You have spoken to people who regularly treat sports people. Have a plan. And I feel it's very useful to go through that plan with the family. And I said to them, look, we're going to go to theatre. I think I'm going to try and fix it for you. I will try and bone graft it from the wrist. I will try my best to keep your scaphoid. I'm not going to do a salvage procedure right now. We're going to be in a plaster for a fairly long period of time because I don't trust teenagers. I definitely don't trust footballers. And I definitely don't trust football teenage goalkeepers who want to play for England. I showed a picture of a pre-printed scaphoid, which I printed for another case. I didn't on this one, but if you have access to a 3D printer and you regularly treat scaphoid non-unions, I think it's a really, really useful thing to do because it gives you a really good idea of the geometry. In the dream world, print both scaphoids, right and left. Hopefully they're not both broken, which some of us have seen before. And you have a pretty good idea of what to expect when you go in there. So I took him to theatre, and I don't have any intraoperative photos here, but I rehearsed what I was going to do. And in my mind, the plan was dorsal approach. I make a little chevron. I move EPL out the way. I lift up the Lister's tubercle for my bone graft. And my plan was curate that big cyst out. Hopefully there would be enough of a cartilage cap to put a screw onto. What if the scan is wrong? What if it's healed? That was something in my rehearsal I thought about, because sometimes you get there and it's healed. Are you going to leave it? Are you going to put a screw anyway? In his case, there was this great big cyst and a definite non-union, which was extremely proximal. I'm just going to go back to that to make sure we're all aware of this. We've got a very proximal non-union, almost breaking into the radiocarpal joint. So my big stress here was that this is going to disintegrate in front of me. Now, luckily it didn't. So I lifted a trapdoor of Lister's tubercle and put a whole lot of bone graft in. And then there was the big decision, how are we going to secure this? I didn't really want to use K-wires because that meant coming out again. And it's not a great fixation. In my dream, I wanted to use a headless compression screw so that I could bury it and not think about it. But there were two problems with a headless compression screw here. Firstly, even the smallest headless compression screws were small because though he was a goalkeeper, he was quite a small guy and it was quite a small proximal pole. So in this case, I actually used a normal, simple 2mm bone screw with a second K wire adjacent to it to stop rotation. I put him in a plaster, and I am a fan of Exogen. You've seen I've published on the Exogen. I make a little window in the plaster, which the company supply you a little hole to put in. And I put the Exogen on as instructions, got him into a splint at 6 weeks, x-rays at 6 weeks, which showed a hint of healing. I did a CT at 10 weeks, and it showed more healing. By 13 weeks, I was convinced it was on its way, and by 4 months, I had him playing football. So this is the early post-operative photos. This is the sort of 3/4 post-operative photos. You can still see some cystic areas within the bone. It looks like the screw, which as you can see is a simple bone screw. It looks like it's prominent, but there's a big cartilage cap, which you've got to remember is there, and it's a little bit thicker in kids and teenagers. And if any of you ever fixed a small child, it really looks weird because it looks like there's a screw floating in the wrist. Did CT scans, and this is our 10-week CT, which very important when you do, and I'm teaching some people to suck eggs here, but make sure that when you're doing the CT scan, that it's formatted along the axis of the scaphoid, because you can cheat and you can lie to yourself and think that the scaphoid's healed. But if you haven't got the CT scan in the right recons, you're going to miss the facts. So I got the scan and I started to feel reassured. And then I think these are probably close to 4 months. There's still a small cystic area, but he's pain-free. He's doing push-ups. He's got full movement. And he's a happy kid. So at this stage, he went back to playing football with contact. In terms of his return to play, until his wound was healed, I didn't let him do cardiovascular work. I'm always a little bit nervous about people training, doing cardiovascular without a healed wound. I know some people will allow that earlier. Once his plaster came off, he carried on with his cardiovascular work, and I let him do kicking and without any problems. By 10 weeks, I was allowing him to throw but not receive the ball. At 12 to 14 weeks, it was just sort of light throwing and light catching so that people could get into the habit of it. And by 4 months was when I allowed him to play full football. Again, if you treat athletes, I find it very difficult to decide when to return to play. It's different to our regular patients, and there's some guesstimate involved. They'll always lie to you about being totally pain-free. Well, the clever ones may not, but some of them will. So what did I learn from this case? You don't have to give up hope if it's a very proximal pole. Have a plan A and a plan B. My other plan was, if it was totally not reconstructible at that stage, come back later on if you still had problems and put in a little cap, a prosthesis. And just remember, you didn't break that scaphoid. You know, I spent a lot of time agonizing over this. I was like, what if I can't heal it? And I sometimes just agonize. And I said, look, I didn't break your scaphoid, and I'll take care of him and I'll do my best to heal it. But sometimes you can't fix every scaphoid. So I think I'll hand over to Rob now, and then we'll do some questions afterwards.
Yeah, thanks very much, Max. Yeah, nice case. So Rob's hopefully going to put this in the context of the literature with the paper that we've got, which is a systematic review. We just need to unmute. You're unmuted. There we go.
Okay. So thanks, Jeremy. So I'm Rob MacFarlane. I'm the current Hand and Wrist Fellow at Chelsea and Westminster, and working with Max. And we're going to talk about this paper. It's Operative Management for Paediatric and Adolescent Scaphoid Unions. It's a meta-analysis last year in the Journal of Paediatric Orthopaedics. So a bit of background, some of which Max has mentioned to us. So 2 to 3% of paediatric hand and wrist injuries are scaphoid fractures. And actually in the acute setting, the vast majority of them will heal with simple closed treatment, and there's a very good union rate. The overall non-union rate is actually, it's very, very low. So it's 1.5% of pediatric scaphoid fractures. there's very little literature on the management of non-union in these injuries, but Golson and colleagues have reported 23.7 union rate with closed treatment, but a lot of cases will need operative treatment. And so the literature is relatively sparse, and there's really only a selection of retrospective case series on this. So this paper was a systematic review and a meta-analysis of studies, and it's specifically reporting the operative treatment of pediatric scaphoid fractures. The authors tell us that they conducted it according to the PRISMA guidelines for systematic reviews and meta-analyses. And their search involved search of Medline, which is essentially PubMed library, the Embase system, and Ovid. And they tell us that, that it was done by both of the senior authors. Excuse me. And so the inclusion criteria were English language reports, it needed to be full text reports. And they said they were including RCTs, cohort studies, and randomized crossover studies, but in reality, it was cohort studies that they were looking at. The pediatric population, so it's those under 18, and there had to be a union rate as an outcome reported in the study that was being selected. Studies were excluded if it was not in the English language. Wider studies of hand fractures where there wasn't specifically a surgical treatment involved. Animal studies and single cases were excluded, and they did not include any reports of AVM. So if we summarize the methods, so they actually didn't include a flow chart in their method. So I've done a simple one here. So it was a simple search based on Boolean logic terms through Embase, Medline, and Ovid, and they came up with over 2,000 articles. And after various inclusions and exclusions and an arbitrary application of a 3-month cutoff for defining a non-union, they had 43 articles. They added 7 from additional grey searches to come up with 50 articles of relevance. And when they looked at those demonstrating surgical outcomes for operative fixation, they came to 14. And then reduced it to 11 based on poor outcome measurement, or a group one had a group that was closed treatment versus operative. So to go through their results, they didn't report it in the easiest way to read. So I've just gone through the basics here. So it was 176 cases, 157 in the bone grafting group, and they were all non-vascularized and they were all fixed with either screws or wires. There were 19 that were not grafted and they were all fixed with screws. And the follow-up time, the mean follow-up time was just under 4 years, so 47, with quite a wide range of 3 months to 96. And the mean age in both groups was sort of early to mid-adolescence, 15 and 14 for the grafted group. So if we go through the results, so apart from one fracture in the whole series, they were all waist fractures. They had one proximal pole which healed with an iliac crest graft. In terms of the time to surgery, it was 8.8 months in the grafted group, 4.8 months in the non-grafted group. And their complications were seen only in the group that was grafted, and they included one infection, some wrist stiffness, and loosening of a screw. And there were no complications seen in the non-grafted group. So their union rate, which is what they synthesized their data and really gave us their main conclusion on, was pretty much equal. So 94.8% in the grafted group, 94.6% in the non-grafted group. When we have a look at their other figures, so they looked at functional outcomes. The range of motion was pretty good compared to the operative side, slightly better in the non-grafted group. Grip strength about the same in the mid-90s compared to the operative side. They had a look at, I think there were 7 or 8 studies that looked at the Herbert classification. And so when they put that data together, they found that a D1 simple non-union, they all united without graft. For a D2, the majority were the majority united, and 61 were grafted, and that was with a screw. And then for D3, which is actually a sclerotic non-union, all were grafted, all had screws, and they managed to have them all united. They looked at the approach, 97% union with the volar approach, 94% union with the dorsal approach, and the volar approach was a combination of grafted and non-grafted. So we have a look at the methodological quality. So we use the AMSTAR tool for systematic reviews and meta-analyses, which include non-randomized studies. And using that tool, it's 7 main criteria, really. And actually, this study failed to meet the majority of those. So did the study definitely have study selection in duplicate? And the authors state that they did do it, but there were no details of any differences between the 2 authors or the 2 searches. There were no details of excluded studies, and so we're not clear which studies had been looked at and then excluded and for what reasons. And they didn't include their study flowchart, so we really were only told that there was the selection of the 47, the 43, and then to 50, and then to 11. There was no assessment of heterogeneity, and there's various methods for doing that quite early in the study protocol, and actually they've not made mention of it at all. And we can tell if you actually look at the references, there is clearly heterogeneity in the studies that were selected, but they have not done a clear assessment of that or reported on it. The risk of bias, we haven't seen anything from the authors on whether they assessed each study for bias or whether there was risk of bias assessed across the studies. And then it was quite a basic meta-analysis, and we will have to assume that they used a random effects model, which is what you'd expect in this kind of study with different cohorts, but they haven't told us which random effects models and how they synthesize their data. And so using the AMSTAR tool, actually, if you have 1 or more major concerns out of the 7 criteria, then actually it puts you in the low confidence group. And I think that's where we are with this study. And so when we look at the reporting quality, the PRISMA checklist is really the most widely used and accepted. It's a 27-point checklist really for how the study was designed, carried out, and then reported. There's quite a few factors lacking. Probably half the criteria weren't met. So we were looking for that clear flow chart, and we really didn't get to see their study selection or the rationale. Again, the assessment of heterogeneity and the risk of bias really wasn't performed. But it's worth saying also that part of the PRISMA checklist asks about subgroup analysis, and that's when we've got a lot more data. But it's fair to say that there was a relative paucity of data here, and so some things really couldn't be met in terms of the PRISMA checklist. And so, what do we know about kids' fractures, kids' scaphoid fractures? So there's been one large review by Golson and colleagues looking at acute scaphoid injuries that were both non-operatively and operatively managed. And they were able to tell us on their Cox regression that open physes actually has a significant effect on union, slowing down your union rate, both in non-operatively and operatively managed cases. The use of bone graft, screw type, and displacement of the fracture are all associated with increased union time as well. And then this was a recent review that was multi-center between the Pulvertaft unit and our unit, and so some of this is Max's data, and this was this year in the Journal of Wrist Surgery, and the authors here reports on a series of 19 cases, and they've had a look at both the non-surgical and the surgical evidence, and actually based on that they've given us a suggested guideline which actually suggests for non-displaced fractures, non-displaced non-unions, you can give a go with non-operative treatment in a cast. And so some final thoughts. So it's quite a wide follow-up range here. these studies, so 3 to 19 months, and there's bound to be an influence on clinical outcome there. The age range from 12 to 17, it does span skeletal maturity, and it may be that we're actually talking about slightly different pathologies between the ages of 12 and the age of 17 in terms of the pathoanatomy and what the endosteal blood supply and the local blood supply is. But how relevant is that to us? We'd have to do some more work on that. So is this study of relevance to the wider surgical community? I think it is, because we haven't seen a lot of evidence on this, and it's actually the first attempt at a meta-analysis. Even if we can criticize the data, there's certainly some very good information in terms of their cohort and the pool data that they've got. Does this help us? I'm not sure it necessarily helps us in decision making between graft and no graft, and I think you'd have to look more closely at fracture pattern and age and activity. But I think certainly it's a reasonable addition to the literature. Any questions?
That's brilliant. Thanks very much to Rob, and thanks very much to Max for his case presentation. And what I'd really like to do is, well, first of all, to look through the Q&A. Max has been hyper efficient and has already answered the hot off the press first 3 questions we had. I do want to just maybe read them out in your comment, Max, and then what I'd like to have that is then maybe turn to Ian and Carlos to tell us what their thoughts are about pediatric scaphoid non-union, perhaps in general. Are these one group? Is this a mixed bag? And do they have a kind of algorithm? And can they really apply that or modify that from the paper? And what would be their thoughts about these kinds of cases, like the kind of case Max had? So maybe we'll bring in Max. What do you think of these the questions we've had? So we've had questions from Alex Nichols, Rebecca Shirley, and Rob Poulter. Yeah, nice to see all of them here.
So I'll go through some of the questions, and we can go through them. I mean, it certainly feels like I'm the boy with the grown-ups between Ian and Carlos here. I'll try and do my best. So yeah, Alex, good question. Do you leave that screw in or not? I think like I said, I treat him like any other patient. If it's an asymptomatic screw, leave it alone. The more you go into the back of the wrist, the more the wrist can get stiff. He got a equivalent range of motion to the other side, and as a goalkeeper, his range is important. Yeah, I guess I was worried that it was irritating him. You could do a metal suppression MRI to see if it is sticking out, but he had a thick cartilage cap. I don't think he was fully ossified yet. So my gut feel is leave it alone. I don't know, Ian, Carlos, what would you do?
I'd leave it alone if it's not causing any trouble. So I've been doing this as a consultant for 20 years. Carlos was my first fellow. We were the same age, and that was one of my greatest privileges as a consultant, to start with Carlos as my fellow. What a wingman to have. But at that time, we didn't have very small headless compression screws. The smallest cannulated screws we had a small head. The first generation Osteomed screws, they went down to 2 millimeters. And the small heads, so I used those with these small proximal poles, and the small heads really didn't cause any problems if they're buried. So I think you'll probably be fine. This wasn't a cannulated screw, but that's neither here nor there. The Osteomed do now make cannulated screws down to 2 millimeters, and I have that set available for any small proximal poles, because I find that even the micro Accutrack, fortunately Accutrack now has micro, which covers 90+% of scaphoid fractures. That's my current go-to screw. It has been for 20 years, but the new version is great. But if it's too small for a micro Accutrack, then the Osteomed 2 millimeter screws, and I think there are a few other companies now do 2 mil screws that the headless. The other thing about the Accutrack is it's slightly cone shaped, so it will tend to put hoop stresses on a small proximal pole and burst it. Whereas the other designs, which have a more straight sort of bipolar device with 2 threads, the thread line is straighter, and I don't think it puts so much hoop stress onto the bone. So that's the screw I would have used here. But before going on to the other sort of wider topics, Carlos probably has learned even more about things than me. Do you want to say something, Carlos?
I was going to say that I would leave the screw in. I tell them that the screw is titanium, it's inside the bone, it doesn't cause a problem, it doesn't beep at the airport, and it doesn't do anything bad. The only ones I've taken is kids that then grow up and then they want to join the army or something, you know, the Marines or something, and they come back and say, "Can you take the screw out?" And then in those circumstances, I'll take it out. But also these guys, particularly sports people, they don't want to have an operation and to have time off. One very important question is what Max was saying about when do they return to work, to sport. And field players, strikers, sometimes they break their scaphoid falling over. And I tend to fix them. I let them go back reasonably soon. We have very good splints now, FA approved, that they can play in. And we get them back reasonably soon, and that's not an issue. Goalkeepers is an issue, and when you see them that the first time, as Max did, you have to tell them that this is a big deal, and you have to tell them this is the end of the season, and then let the drama blow over. And if they go back early, they'll be very glad and very helpful. I'm very grateful for that. But you don't want to have the constant argument, when am I going to go back to training and all that kind of thing. You say, sorry, mate, that's the end. I'm sorry. You need to take a long-term view. We need to get a good rest. And that's it for this season. And then they know, the parents know, the coach know, and the pressure's off.
I think I agree with that entirely. It's a bit more difficult with rugby players because they're not allowed to wear splints. And I usually, so I tell them they're going to be in a cast for 2 or 3 months, and another 2 or 3 months of rehab minimum till you get back to playing. So it's 4 to 6 months for my rugby players. I don't know whether that's too conservative, but I think that's a reasonable time frame to give them.
Yeah. Well, there was an interesting medical legal case. It's not a young one. It's an adult goalkeeper, and he had his scaphoid non-union fixed. Goalkeepers are very particular. If they have wrist pain, they don't tell anybody till the end of the season. And then the Monday after the season is finished, they all come and see you, and they all want it fixed that week. And so there was a goalkeeper who playing for a Premier League club who had a scaphoid non-union, who was fixed by a hand surgeon reasonably well. Unfortunately, it didn't heal, and he lost the place in the team. And then he was on loan on another team. He needed another operation, ended up playing Championship League, which was fine. And then he sued the surgeon for the difference in earnings that he would get, which he estimated at £1.5 million a year for the rest of his career, because the scaphoid had not healed. But the thing that was funny about it is that he went to the High Court, and there were several pundits arguing if he was playing Championship because of the scaphoid or because he just wasn't very good, really, you know. But you need to be extremely careful with this because the stakes are very high.
Yeah.
Yeah. Thank you. Yeah. And if you don't, again, the message is if someone just wanders into your clinic and you're not used to treating sports people, and I'm in no way a regular treating, but they will come to your door, phone a friend, question widely, because the pressure is immense and you feel big. You feel, oh, I'm the man. They've come to see me. Just treat them like you would ordinarily. Ian.
I was just going to sort of make it, I mean, you've both done a great presentation there, and Rob, that was really good analysis of the paper. I think my take on it is, if I'd been writing that paper, or if I'd set out to write that paper, and it's difficult because the numbers are so small, but you know, I think you're absolutely right. There should be a split between the true paediatric ones and then the adolescents. And in my own mind, I have a cutoff around the age 14. So if they're under 14, then they're true paediatric fractures, and if they're over 14, they're nearly all blokes anyway. I suppose if they're female, that the age cutoff's probably slightly younger, but then the 14 to 18 is a different bag, really. also this paper, that it was a bit nonsensical, because they had basically what I would classify as delayed unions. So anything from 3 to 6 months I classify as a delayed union.
Yeah.
And in children, the evidence would be that, you know, maybe a quarter or a third of them will heal just in a cast anyway. So they're a different kettle of fish. Whereas beyond 6 months, that's definitely an established non-union, and they have a much higher chance of needing an intervention in my book. So they've compared apples and oranges in the paper, which is unhelpful. The other split I would definitely, I mean, they tried to do this a bit with using whether it was waist or proximal and the Herbert classification, but a world of difference really between a waist fracture and a proximal pole at any age. And they didn't really mention poor vascularity, hypervascularity, or AVN, which again is another world of difference. So you need to stratify for those factors, and definitely the time from the injury to the time of the operation is, we know that's for adults a huge issue. I suspect that you've got a lot more time to play with children and adolescents, but it's still a major factor, and you've got to kind of stratify your cases according to that too, whereas they had them all really in sort of one bag, which was a bit crazy really. But those are the sort of those, and I think you stressed it as well, Rob. We wrote a case report a year or two ago about a proximal pole non-union in a lad, I think he was about 13 when he sustained it. He saw me when it was a year or so later. He had an established non-union, about 6 months later, but he was completely asymptomatic, and he wasn't really keen on having anything done. So we said, well, fair enough, we'll watch and wait. And at a year, he was still ununited, but at 18 months, he'd actually united. So even a very proximal pole, I mean, I can show you the pictures. I don't know if I can share my screen, probably not, but you know, the radiographs and the sort of scans look very much like Max's case. And I thought, this is really not going to heal ever in a month of Sundays, but he was asymptomatic, and it was a bit difficult to justify doing something. So he was quite happy still playing basketball and things. So we waited, and remarkably it healed, which I was completely against the odds. So the scaphoid can always surprise you as well.
Yeah, I think that's a very important comment, because my feeling is that these scaphoids want to heal.
Yeah.
And even if you're going to fix them, what I'll do is I'll book them, and it will take me, and the NHS will take me a few weeks to get it done. I'll put them in a cast, and then X-ray them again on the day they come back for the operation. And I found a few that have healed.
Yeah. I think the cutoff between when they might heal or not heal, when they stop behaving as a paediatric one and go to basically an adult, is when the physis fully fuses. So I think it's the environment, the growing environment, and the additional growth factors and the blood and stuff that's there that probably makes it a different beast.
There is a problem as well. Sometimes they've been a non-union for a while, and they've lost a fair bit of bone, and then they've healed, but they've healed very, very bent, and they give you a malunion with a very marked dizzy. And I've had 3 that developed a dorsal mid-carpal instability, and I've ended up doing a scaphoid osteotomy for those ones. So if they are very deformed, very bent, I probably don't want them to heal. I much rather go in and graft them and screw them. And that's one of the issues about the paper. The ones that were grafted did worse than the ones that were not grafted. The reason is the one that were grafted is the one that were very deformed with a bone deficit, and they were much worse.
Needed a graft, yeah.
And needed a graft, you know. Because the other ones, you can fix them percutaneously, and they do heal, even months down the line.
I don't know whether Nick Riley, my colleague's on the line, but he did a very nice one of those recently with a bone graft, a malunion from a young chap who's a malunion, with a really bad malunion. If it's a tolerable malunion, I'd probably rather tolerate it, but if it's really bad, it's worth probably correcting.
Yeah, it's quite remarkable how they will, if you don't fiddle too much and they do heal, how the carpal bones will remodel. As long as they're not too deformed.
I do very occasionally do a vascularized bone graft in an adolescent, and if they've still got an open physis, my routine first time vascularized bone graft, this is only if they've got AVN problems. Would in an adult, I would routinely, if possible, use a pedicle bone graft from the distal radius, either from the volar side or traditional Zeidenberg if there's an proximal pole. But in the adolescents, if they've still got an open physis, I don't really like the idea of going for the distal radius, and I think you get poor quality bone. It's because it's got a bit of physis in it, and it's quite crumbly. So I use an iliac crest wedge graft, but then I'll use the superficial palmar branch of the radial artery as a distally based AV pedicle tied off, and put your graft in, put your screw in, drill an oblique hole through it, and then feed the vessel through. That's quite a well described technique originally in Australia.
There's
about 1998, just when I was there as a fellow, just after that. So I've done a one or two handfuls of those over 20 years, so that's a pretty rare occurrence. I've got some slides of that, but again, it's very difficult to share my screen, but it's a useful thing to have up your sleeve if you're in that really, really rare hen's teeth situation with a young person.
Yeah, no, I agree. Sorry, it's Alistair here.
Oh, Alistair's there.
I hadn't seen one of these for a long time, and then 10 years ago I had a 10-year-old, and we had no idea when the injury was, and it was extremely collapsed, and we took iliac crest. I put about a centimetre graft in. It's really hard to judge the dizzy because the lunate's obviously not ossified fully at that stage, so they always look as if they've got a bit of dizzy anyway. And I put a microacutract screw in that just come out, and I left it prominent, and I just took it out at 4 months, and it has healed. And then 6 months later, I had an 8-year-old with exactly the same thing, and then a 12-year-old. So I had 3 in a row. And then I haven't had one. I've had lots of 14 and 15-year-olds, but I haven't had any others. And I've got one right now, waiting for COVID to finish, in another 9-year-old, with a very, very collapsed, and the whole of the central scaphoid is a cyst. But I just split the apophysis, take a wedge graft, nothing vascular, but a single screw retrograde, and then I'm taking them out in this limited series. And I leave them prominent, and they seem to heal very, very fast.
That's a very young age to be doing grafting, but yeah, I think I've probably only done 1, maybe 2 of that. You know,
I've had one 8-year-old who had 7 siblings, and I left the scaphoid for about 9 months, and they were all brothers. And every time I came to the clinic, it looked like one of the brothers had jumped on another brother's head, and the family would show me videos of kids going down hills on bicycles. And I was convinced that this thing would heal. I went so far as to scanning the other wrist and looking for bipartite scaphoids. And yeah, he's the one I eventually took to theatre, and it was a non-union. And I just put a little dusting of cancellous graft, a couple of K-wires, and it just went from a non-union to a union very, very quickly. And it just wanted that little bit of stability, and I tried stability in a plaster, it didn't work. Another trick which you can use is by Francesco Soldado, who's a super guy in Barcelona. I don't know who knows him, who doesn't know him, but he will do a metacarpal periosteal flap of the first metacarpal. Are any of you familiar with that? I've never done it, but yeah. I've heard Francesco talk about it, and he swears by it as a reasonably simple thing. And I mean, he uses periosteal flaps to get huge tumors to heal all over the body. But it's reasonably simple. You just take this flap, again, based on the same artery, superficial branch from the radial artery, put it onto your scaphoid, and he swears by it. Have any of you got experience with that?
No, I know you can take a bone graft or a periosteal flap from the second metacarpal on the back, but
I'll share my screen. Have I got the screen? I'll share my screen with you quickly just to show you the reference. I do think it's worth reading. Let's see if I can screen share. Just a second. There we go. I don't know if you just take a photo with your phones or something like that, but he's written it up quite a few times in a few different places. I mean, Francesco is one of those guys for whom I think just about every operation works, but worth a trick to consider. Jeremy, what did you think of the methodology of the paper?
Well, I mean, I think, Rob's done a really nice job. So, I mean, I think a little bit about what we talked about last time, the idea of looking at the reporting guidelines of how well a paper is written, which Rob did with Prisma, and then look at the actual methods and the methodological quality here with AmStar 2. Part of the problem is those two tend to relate very closely, and partly that's because studies that aren't necessarily well written tend to not necessarily be well conducted, but also studies that aren't well written tend to be hard to unpick because you don't usually get to find out what they did because it's not all that well written. Yeah, I think there were quite a lot of limitations, as Rob's pointed out. I think it's a tricky area to study. I mean, to me, as somebody who's not a scaphoid surgeon, the results all sound astonishingly good, and you really wonder a bit about publication bias and what's kind of gone in here. If you have a series of a few of these that you've done that all do horribly, do you stick that out in the literature? Or are what we seeing here the good end of the spectrum? And maybe this relates a bit to what Ian's saying, that there's maybe a conscious or subconscious drive to publish the delayed unions because they probably get a better result than your true non-unions. If you've got the later, data on later ones, maybe it doesn't give such a promising outlook. That's the question I kind of have. So some challenges for the paper, but not probably an easy area to pull together data helpfully. And I think there are some real tricky points here. And as we say, the other problem, as Carlos has pointed out, is when you're meta-analyzing cohort studies that are not randomized, well, why did some people get grafted and some people not get grafted? There are reasons for that. And unless you use some kind of statistical modeling to adjust and account for that, and it's a bit tricky. So that's my thoughts. And I thought Rob's kind of explained most of it, and I kind of really agree with him.
Yeah.
I think it'd be really nice to maybe ask the panel about, there's a question here as well from Ernst Smit from the Netherlands. So thanks for joining from the Netherlands. He's a hand surgeon there, and he's got a 13-year-old soccer player playing professionally who's had a non-union for a year with pain and radial deviation, a waist fracture with 3 very large cysts mid-distal pole. And his questions really are, do you have experience with the metatarsus plate and removing it at 12 weeks, quite specific? And where do you harvest bone in a professional soccer player with open physis? So I'd be really interested to hear what our panel thinks of that.
Thanks, Amy. I have done that, and I did one recently. You can plate the scaphoid as well as fix it with a screw. Some sets, like the Medartis one, has a specific place for that. You don't necessarily need to use that one. You can use some other one. That one fits reasonably well. And if there is a scaphoid that's got a very big cyst with a very big handbag, that's helpful. And we're lucky that we have available a 3D printer. So what I've done is get the CT, get the 3D printing, and correct it, and put a plate, mold the plate exactly, and put the screws and measure all the screws. And then sterilize that plate and those screws. And then when I do the correction for the scaphoid, put that in. And you think it's going to catch when they flex the wrist, but in fact, often it doesn't. And I leave them for longer than 3 months because it depends on where in the season they are. They're high-level sports people, and we take them at a convenient time. But I'll tell you what convinces me that these are worth exercise is that the last one I did, I reconstructed, put a bit of graft, a bit of mesh on the plastic one that's doing all this on a bench, put the plate, molded, looked really nice. And then I turned it around and I had rotated the scaphoid about 30 degrees. I had to undo it and do it again. And I made all my mistakes on the bench. So when I did it on the patient, it looked really, really skilled and elegant because I had already made all the mistakes the week before. And I find that a good exercise to do, and they do well, and they heal like anything. They heal really quickly. Because they tend to be sports people, I take my graft from the distal radius proximal to the physis. It worries me that if I take it from the iliac crest, it's going to be sore for quite a while. And then it delays the getting back to jogging and the cardiovascular exercise and all that kind of thing that I let them do quite early. And the other thing I learned with these guys is I put them in a Scotch cast including the thumb,
Yeah.
quite long in the thumb. It's not because they heal better, but if you include the thumb, they cannot do anything with it.
Yeah,
Because I
absolutely.
had some of them come back with the thumb, with the cast broken, and you say, how did it break? I said, oh, I was doing press-ups and it just cracked.
Or motocross or something like that.
And they think that's normal, you know.
I've found this a slide I could share with you, which includes some pictures of Damien Island surgery, which would be nice because Alistair's on the line. There might be other people that know Damien. Should I put that's of the technique I was just talking about? I'll try and share my screen.
You'll be able to share at the bottom.
Yeah, if I'm not massively, here we go. Share, and it's that one. Share, and then if I go into that, yeah. So so this is me. These are slides from '99 when Damien was operating, and this is actually a sort of young adult, but you can do the same thing with iliac crest from an adolescent. Be aware that the physis in their iliac crest will also be open, so you can take the graft from below the level of the physis in the crest. You can take a decent bit of graft from there usually, or just take it tricortical and then break off the bit that's got the physis in it. But you can take your iliac crest graft, and then Damien's technique was to actually drill a hole through the bone graft, and then with the long, you leave the tie when you tie the superficial palm branch of the radial artery, you leave the tie long, and then you can use that to thread it through the bone. And then you put it into your scaphoid down here with the AV pedicle going in, and then he actually put wires in. If you want to fix it with a screw, the alternative way around of doing it is to put the graft in first, and then to drill an oblique hole just beside where the screw is and feed your vessel through that way. If you use a loop of nylon or something, you can sort of do almost a Seldinger technique to get the graft through quite easily, and then pull the vicryl tie up here, and I usually just stitch that into the soft tissue so it can't pull out. And the principle is that you get a vascularization front running out radially from all around this AV pedicle. It's important to have the veins with it. And Wayne Morrison's entire research career was really based around that principle of revascularization from a tied off AV pedicle. So I think it does work, and it's a useful thing, particularly if they've got an open physis in the distal radius. I don't know if this will advance. That's radiographs. So you can tell this is a pretty old radiograph of mine because of the age of the screw. This is a very ancient Synthes cannulated screws. The derotation KY that I've left in, but this was a pretty young patient with wide open physis. I can't remember the age of the patient, but so that's my go-to if you happen to find avascular change in this proximal pole.
Brilliant. Yeah.
Very nice. Very nice.
Yeah.
So I
Yes,
think,
and just in terms of the iliac crest, what Carlos was saying earlier, I started opening them. I think I must have been shown it by someone, possibly by Damien Ireland. But when you do a Salter osteotomy or something that horrible, you spend the first inch just cutting through cartilage that folds open before you get to the bone, and it closes really nicely. So it's a direct approach straight on to the iliac crest. And then you split the cartilage. You can take out as much bone as you like, and then you sew the cartilage back together again. And I don't think it didn't bleed much, and they don't get too much morbidity from that. So they should be running by a week or two. But for an 8-year-old, I would do that rather than radius, because it's certainly all the ones I've dealt with have huge defects, and you need at least sort of 8-10 centimeters of quite a solid graft as well, and ideally scoop a little bit of stuff out. I don't know what the cysts represent in a scaphoid. I think the cysts are probably quite a healthy sign. In fact, there's clearly been osteoclastic activity. And I'm not sure if they're necessarily too bad. And the cysts, of course, are absent bone, but something else is present. So the screw hold in the cyst doesn't seem to be a problem. So they don't worry me too much.
Any other thoughts from the panel on cysts?
I mean, I usually curette them out and get the sclerotic bone that's around them inside out. So you're back to cancellous bone, and then I'll just pack them with cancellous bone, and then put in my either iliac crest non-vascularized or vascularized or my pedicle radial bone graft. It's quite nice to think that you could, if you're doing a vascularized graft, if you've got a big cyst, that you can shape the graft to go into the cyst, but it's actually quite difficult to do that.
Yeah, I like to make them disappear the same way. What it's worth.
Brilliant. Well, I think I mean we've had an hour now of illuminating discussion. Really great case. Thank you very much, Max. Thanks to the Chelsea team. Really nice analysis of meta-analysis, systematic review of a tricky problem, but with some tricky challenges in the literature then too, and really enjoyable contributions from our panel. I'm very grateful for them all joining this time in the evening from a long, M40 and beyond corridor right up to Derby. We've really enjoyed the questions and really hope that the audience have benefited from today. I've certainly learned a lot. It's been very much an enjoyable part of this. I think you'll all be very welcome. The idea is to keep running this journal club on a regular basis, rotate the centres that are talking, places that are very welcome to put forward that they've got an interesting case and a paper, and all together something, and we'll discuss it and hopefully can all learn together. The final comment from Bob Porter, expressing his thanks from down at the Kingdom of Cornwall. And other than that, I think I just want to say thank you very much to everyone again, because it's been a very pleasant evening. So thank you.
Thanks very much, everybody.
Thank you, guys. Good to see you
Bye-bye.
all.
Goodbye to everyone online.
Bye. Nice to see you.